Hello and welcome to the Deep Dive. We're your shortcut to getting truly well-informed, especially when you're short on time. Today we're tackling two really critical lower limb injuries, ones you'll definitely encounter. Tibial plateau fractures and PCL avulsion injuries. These are complex, they challenge your thinking on joint restoration, posterior knee mechanics. Lots to unpack. Our discussion today is guided by the fantastic Ortho Made Simple notes. You can find those at mokyingren.sg. They're put together by Dr. Mok Ying Ren, a sports surgeon at National University Hospital in Singapore. He got his FRCS back in 2022, so very current insights. Our mission, to pull out the key details, the clinical pearls, those aha moments you need for understanding these, and, well, for your exams too. Okay, let's dive in. Tibial plateau fractures first. When we think about these, Schatzker classification usually comes up immediately. Can you walk us through the types?
Absolutely. Schatzker is, well, it's foundational. It runs type 1 through type 6. Type 1 is just a simple split. Type 2, that's a split and a depression. And that one's key because it's by far the most common type you'll see.
Right, the type 2. Good to flag that frequency.
Then you have type 3, which is supposed to be depression only. Type 4 involves the medial plateau. Type 5 is bicondylar, both sides involved. And type 6, that's the big one, with metaphyseal dissociation. The joint surface basically separates from the shaft.
Okay, clear breakdown. Now, you mentioned type 3, the depression only. I've heard that described as almost mythical, like you hardly ever actually see it.
Yeah, that's the reputation. It's certainly very rare.
So hypothetically, if one did occur, what's the thinking on the mechanism? How do you get just depression?
Well, the theory involves a combination of forces flexion and valgus, and it relates to the anatomy. The lateral tibial plateau is convex, it's less dense bone. Combine that with the femur rolling back during flexion, and you could, theoretically, get that isolated push down, that depression.
Interesting biomechanics there. And crucially for our residents listening, compartment syndrome, which Schatzker type screams high risk.
That's definitely type 6, that metaphyseal-diaphyseal dissociation.
Yeah.
It implies a huge amount of energy, massive soft tissue injury.
So type 6, be on high alert.
Absolutely. It's a classic association, both clinically and for exam purposes. You have to monitor those patients incredibly closely.
Beyond the textbook signs like pain out of proportion, are there any subtle clues, maybe something a patient says, that makes your spidey sense tingle for compartment syndrome in these type 6 injuries?
That's a great question. Sometimes it's not just the pain level, but the character of the pain, a feeling of intense pressure, like the leg is going to burst, or maybe increasing need for breakthrough pain meds, even subtle weakness starting in, say, ankle dorsiflexion before you see a full foot drop.
Right, those little changes.
Yeah, and honestly, sometimes it's just that gut feeling. The patient seems too uncomfortable for what you're seeing initially. Low threshold for checking pressures is key.
Excellent point. Okay, moving beyond Schatzker, there's Lewis classification, the 3-column theory. How does that help us practically, especially with surgery planning?
Lewis is brilliant for planning, yeah. It divides the plateau into 3 columns, medial, lateral, and posterior. Simple as that.
And how are those columns defined?
By specific landmarks. You use the anterior fibular head, the posterior medial ridge, the tibial tuberosity. These define the zones. And the core idea is, if the cortical wall of a column is broken, that column is considered fractured.
Okay, so a cortical breach equals column involvement.
Exactly. And interestingly, going back to that Schatzker type 3, the pure depression, in Lewis' system, since the cortex is intact all around, it's actually a 0-column fracture.
Okay, that makes sense. So it connects the system.
It does, and it directly informs your approach. Which column is broken tells you where you likely need to put a plate, which incision to use. It streamlines things.
Seems very logical. Are there situations where maybe the 3-column model feels a bit insufficient, maybe very complex patterns?
Yeah, I mean, it's a model, right? So with extreme comminution, where everything's shattered, defining distinct columns can be tricky. And sometimes specific fracture lines like a big coronal shear in the back or a tricky posterolateral fragment might need more nuanced thinking beyond just which column. But as a starting point, it's incredibly helpful.
Understood. So you suspect a tibial plateau fracture. What are the absolute must-do investigations? And on the CT, what specific details are you hunting for?
CT is king here. Absolutely essential.
What are you looking for?
Several things. 1, column involvement using Lewis guides the surgery. 2, how much depression is there? Do I need bone graft or substitute? 3, fracture extension, how far down does it go? Affects my incision. 4, is the joint involved? Any fragments loose? Meniscus trapped? And 5, critically, Look for those coronal plane fractures, usually posterior. They often need specific posterior plating.
Got it. And acutely. Patient comes into the ED. What's the immediate game plan?
ATLS first,
Obviously.
always. Life over limb. Stabilize the patient. Then for the limb, think about bridging external fixation, especially if it's high energy or the patient needs other procedures first, and constant vigilance for compartment syndrome. Serial checks.
So the mantra.
Span, scan, plan. Span it with an X-fix if needed, scan it thoroughly with CT, and then plan your definitive fixation.
Right. So after span, scan, plan, we get to definitive management. What's the overall goal when we take these to the OR?
The aims are really fourfold. 1, restore that smooth articular surface congruity. 2, get the alignment right. 3, achieve stable fixation so it holds. And 4, allow for early range of motion. That's crucial to prevent stiffness.
And the approach follows Lewis columns.
Directly. So that zero column fracture, the isolated depression, usually an anterolateral approach. You'll use a lateral plate, maybe some rafting screws under the joint surface to hold it up.
Okay. What about single column fractures?
Pretty straightforward. Lateral column only, anterolateral approach, lateral plate, medial only, medial approach, medial plate, posterior only. Posterior approach, usually a posteromedial plate.
Makes sense.
Oh, and if it's posterior but involving that tricky posterolateral corner, the Frosch approach is often the best bet there.
Right. The Frosch. Now, the complexity ramps up with 2 columns involved, doesn't it?
It does. That's where the planning gets more detailed.
What's common?
Lateral plus posterior is the most frequent combo.
And the approach.
Usually requires 2 incisions. You'll need a posteromedial approach, often fixing that posterior part first with a plate. Then an anterolateral approach for the lateral side with a lateral plate.
Fix posterior first, then lateral. Okay.
If it's medial plus posterior, then a medial or posteromedial approach using both medial and posteromedial plates. Medial plus lateral usually means dual incisions, anterolateral and medial approaches.
And if all 3 columns are involved?
That's often the most complex. You'll typically need both anterolateral and posteromedial approaches, sometimes requiring 3 separate plates to get stable fixation everywhere.
Okay, that's a lot of hardware potential.
Yeah.
So backing up slightly, how do you decide who needs surgery versus trying non-op? What tips the balance?
It's a combination. Patient factors are key. A young, active person with high demands. You're leaning heavily towards surgery to restore anatomy.
And injury factors.
Significant displacement is the big one. Any step off in the joint surface, say more than 2 millimeters, or significant depression, maybe over 3 millimeter that needs fixing, or if there's instability or the joint just won't reduce properly closed, surgery is strongly recommended then.
Let's do a quick scenario for the residents. Schatzker 2 split depression, most common. How would you typically fix that, assuming the CT fits the standard pattern?
Right, Schatzker 2. Assuming CT confirms it's mainly lateral column, no major coronal line, it's usually manageable with a single plate. You'd use an anterolateral approach, put on a lateral buttress plate, and likely use those rafting screws subchondrally to support the depressed segment.
Okay, standard lateral plating. Now let's ramp up the complexity. Schatzker 5 bicondylar, maybe there's coronal fractional line, maybe all 3 columns are involved. What's the strategy?
Okay, Schatzker 5, bicondylar, complex. That's almost always a dual approach job. You'll likely need that posteromedial approach, especially if there's a coronal fragment posteriorly. You need to buttress that, maybe with screws perpendicular to the fracture line, and you'll definitely need an anterolateral approach as well for the lateral side.
This raises a key point for bicondylar fractures. The sequence of fixation. Is there a standard rule?
There is a very important rule of thumb, yes, and definitely one to remember for exams.
I guess.
Always fix the medial column first, then fix the lateral column to the stabilized medial column.
Medial first, then lateral. Why?
Because the medial column is typically the main weight-bearing pillar, and it's often less shattered, less comminuted than the lateral side. So you build the strong wall first, get that stable base medially, and then you have something solid to reduce the more complex lateral side against. It makes the reduction much easier and more reliable.
That's a great way to think about it. Build a strong wall first. What about adjuncts? Things that help during surgery.
Yeah, several useful tools. A femoral distractor can be great for pulling things out to length and helping with indirect reduction. Arthroscopy can be used too, helps you see the joint surface directly, assess the meniscus, maybe even repair it.
And bone substitutes for the voids.
Sometimes used, yeah, if there's a big depression void. Calcium phosphate gets mentioned for its compressive strength, though there's debate. Some studies, like Murphy's, question the benefit, especially now with strong locking plates. It might not always be necessary.
Okay, interesting point about substitutes.
Yeah.
Now, shifting gears slightly. primary cap. Total knee replacement, TKR. When would you actually consider doing a knee replacement for the fracture itself?
It's not common, but definitely an option in specific cases.
That's just.
Well, if the patient already had severe arthritis in that knee before the fracture, or if the fracture is so bad, so comminuted, especially in an older osteoporotic patient, that you think fixation is likely to fail. Significant bone loss is another factor. Also, sometimes in patients where you really want them weight-bearing quickly, maybe due to other injuries or frailty, TKR can be considered.
Are there contraindications?
Yes. A big one is if the tibial tuberosity is also fractured. That makes the TKR technically much harder because of the extensor mechanism attachment.
Right, the patellar tendon insertion.
Yeah.
So if you are planning a primary TKR for a fracture, what are the key pre-op considerations, especially when the landmarks are all messed up?
Good question. Restoring the joint line height is absolutely critical. You can't just guess. You need to assess the bone stock, carefully anticipate needing stems, maybe metal cones or sleeves to fill defects. Have them available. You'll need intraoperative imaging like fluoroscopy, and have all your fracture tools ready, 2 plates, screws in case you need them for supplemental fixation around the TKR components.
And determining that joint line when the top of the tibia is fractured.
You have to rely on other landmarks. The classic ones are about 1 centimeter above the tip of the fibular head laterally and about 2.5 centimeters below the medial epicondyle of the femur. Those give you reliable references.
Excellent. Thanks for clarifying that. Okay, that was a really thorough look at tibial plateau fractures. Let's switch gears now to PCL avulsion injuries. Different mechanism, different part of the knee.
Right. Often a very specific mechanism, too.
Which is, and what's the immediate must not miss associated injury?
The classic is the dashboard injury. Knee flexed, direct blow to the front of the tibia, pushing it backwards. And the absolute critical thing you must exclude right away is a posterior hip dislocation. That's a true emergency. Can cause a vascular necrosis of the femoral head if missed. Check the hip.
Check the hip. Got it. So for the PCL avulsion itself, what investigations help you assess everything, bone and soft tissue?
MRI is great for looking at the PCL substance itself and any associated injuries, meniscus, other ligaments. But for the bony fragment, the avulsion part, a CT scan is really vital. It shows you the size, the displacement, how comminuted it is. That really dictates your fixation plan.
Okay, MRI for soft tissues, CT for bone detail, and surgery. What are the main approaches to get back there and fix it? I know Burks and Schafer's is often mentioned.
Yeah, the Burks and Schaffer approach, described back in 1990, it's a workhorse. It's that inverted L-shaped incision, medial limb goes down. You develop a plane between the semimembranosus and the medial head of the gastrocnemius. The gastroc actually helps protect the vessels while you retract. Then a vertical cut in the capsule. You can release the gastroc origin a bit for more view if needed.
Is that the only way?
No, another common one, which some find gives a better angle for screw placement, is the direct posterior approach, or popliteal fossa approach. That's usually an S-shaped incision.
And the key structures there. It sounds like a busy neighborhood.
It is. You have to be meticulous. Superficially, you'll encounter the short saphenous vein, medial sural cutaneous nerve. Deeper, the tibial nerve, common peroneal nerve branching off laterally, and deepest, right against the bone and capsule, are the popliteal artery and vein. Remember, AVN artery deep, then vein, then nerve superficial, and they run slightly medial to lateral too. You have to know that anatomy cold.
Absolutely critical neurovascular structures back there. Okay, so you've navigated the approach. How do you actually fix the bony fragment?
Typically, cannulated screws with washers are used.
Cannulated for accuracy over a wire.
Exactly. And washers to prevent the screw head pulling through the fragment helps distribute the force.
Now, post-op rehab. You mentioned something critical here, especially about hamstrings. So it sounds like a potential pitfall.
Huge pitfall. This is absolutely key. Post-op, patients often go into a Jack's brace.
What's that?
It's a special brace, 4-point fixation, designed to push the tibia forward to counteract posterior sag and protect the repair. And the exercise instruction, this is vital for residents to tell patients start closed chain exercises, really focus on strengthening the quadriceps.
Okay.
There's UT, and this is the pitfall, you must avoid isolated hamstring exercises. No hamstring curls.
Why not?
Because the hamstrings attach posteriorly. When they contract forcefully, they pull the tibia backwards, potentially displacing your nice PCL avulsion fixation. It directly stresses the repair site. Ah, okay. So quads, yes. Hamstrings, no. At least initially. That's a really important distinction.
Crucial distinction. It's a common mistake if not emphasized.
Beyond that rehab point, what about long term? Even with good fixation, are there potential issues residents should be aware of down the line with PCL avulsions?
Yeah, even with good healing, some patients might have some subtle residual posterior laxity. It might not be grossly unstable, but it can change the knee's mechanics,
Leading to
potentially leading to increased wear and tear, especially in the patellofemoral joint over the long term. Stiffness is another one, particularly losing that last bit of extension, so early motion is key. And while less common with good fixation, non-union or malunion of the fragment can happen, leading to ongoing pain or instability. Patient compliance with rehab is really central to minimizing those risks. Wow, okay. What an incredibly detailed deep dive. We've really covered a lot of ground, the classifications, the surgical thinking, those critical nuances for both tibial plateau fractures and PCL avulsions. We went from Schatzker and Luos for the plateau, nailing down those approaches based on columns.
right, understanding that medial first fixation for bicondylar fractures.
Exactly. And then navigating the posterior knee for PCL avulsions, avoiding those rehab pitfalls. It gives you, the listener, a really solid foundation. And remember, as you prep for exams, these details aren't just abstract facts. They directly impact how you'll diagnose, how you'll manage these cases, and ultimately patient outcomes. It's all about that balance, getting the joint surface right, getting stable fixation, but tailoring it to the patient and the specific injury pattern, applying the knowledge wisely. This deep dive, like our others, drew heavily from the OrthoMate Simple Notes again. Find them at mokyingren.sg, a fantastic resource. As you continue learning and serving in orthopedics, remember it's not just about the knowledge, but the wisdom in applying it. There's a great reminder in Proverbs 11, verse 2. When pride comes, then comes disgrace, but with the humble is wisdom. May humility guide your learning and practice. And as you use your skills, remember verse 4. Riches do not profit in the day of wrath, but righteousness delivers from death. May you find blessing and clarity, wisdom, and doing right by your patience. Thank you for joining us on the Deep Dive. Until next time, keep learning, keep growing, and keep making that difference.